first panel of the day, focused on the power of community-based approaches. And it is my pleasure to introduce our moderator, Matthew Woodruff, who is so kind and to step in for the last minute for Scott Coffin, who was pulled away by an engagement with Representative Barbara Lee. So we forgive him for that. And Matthew is here, and we're glad that you're here, Matthew. Matthew's the Chief Operating Officer at Alameda Alliance for Health, the local health plan that provides healthcare services to over 350,000 low-income residents in Alameda County. In his role as COO for the last 8 years, he's successfully implemented a good number of programs. Some of them we're very familiar with, the Whole Person Care Pilot, vaccine programs and campaigns, and multiple CalAIM initiatives. So Matthew, thank you for being our moderator for this panel, and I'll hand the floor to you.
Great, thank you. Thank you very much, Wendy. And I want to thank the keynote speakers, Mr. Chan and Dr. Hill. Way to start off the day with hitting all the big topics that, frankly, we probably don't talk enough about. So I want to thank you very much for bringing all those to the forefront. That was just amazing to hear and listen to. And as we get more into the day, I think we're going to hear more about them. So I just want to thank you both for that. Don't want to spend more time talking, so I'm just going to jump right in probably and announce the panel so we can move things along. So I'll start off with announcing our panel. We got a wonderful panel to talk about. The discussion today is about the power of community-based approaches. And we have a cross-section panel that's going to do a fabulous job. So I'll start off with introducing the panel with, we have Serom Sanftner, who's a licensed clinical social worker and Vice President of Program Services at East Bay Innovations. Pamela Powell has a master's in education and is a program manager at Alameda County Social Services Agency. Sonya Frost has a master's in social work and is the division director at the Department of Aging and Adult Services. Adult and Aging Services. Duch is a licensed clinical social worker and a senior case manager at Life ElderCare. And Roland is a registered nurse and has a master's in business administration and is the East Bay Continuum Coordination of Care Services Director for Kaiser Permanente. As you've already been doing, please put your questions directly into the chat. If we have time, we'll try to get to a couple at the end. If we don't, I do believe that somebody's recording all those questions and they will be released later on after the conference is done. So without further ado, I believe, Roland, you are up first and take it away.
All right, thank you so much, Matthew. And good morning, everyone. Thank you for the Senior Services Coalition for inviting us. Very happy to be a part of the conference today, and wanted to thank Wendy for your warm welcome. Wanted also to follow up with Terry's comment about the working across organizations. What a great segue to describe the content of what I'm going to be presenting today. Without any partnership of community services, we would do a disservice to our population. So thank you for that great segue. Brief agenda, we're going to look at a caring moment, the current background, current state, as well as our project and the future state, presenting some performance outcomes, and then opening for conversation. Next slide. Thank you. So I know, Wendy, you offered a lot of very powerful data, so I'm not going to duplicate that. But again, just to echo your sentiment and your the description of our population in the county of Alameda. So clearly the population is aging. We have a trend for severe chronic conditions that is impairing our elders in the community and the county. They also have multiple challenges, including financial capacity. We have nearly 10% in a poverty rate in the county currently, as well as many insecurities, including food, sensory ability. they're prone to falls. Language can become a challenge as we address social determinants of health to clearly understand what the necessities may be for some of our elders. Education can be a barrier. Access to care is a challenge for many of our elders, either physically or having the ability to understand how to connect with a physician or a caregiver. Confusion about self-care and benefits, as well as access to medications or other treatment modalities. As Wendy mentioned, also living alone is a challenge. And then we're noticing the inability to use technology to virtually connect with some healthcare provision of services. Next slide, please. So the background is we are really focused on utilization of our inpatient care, primarily the hospital, the ED. And what we're noticing is, on average, a readmission rate of 14.9% is affecting California, the whole state. While in Alameda County, we are exceeding that rate at 15.6%. So you can see that more patients, more community individuals need acute care hospitalization. And preventing readmissions would certainly impact on the overall state expenditure, as well as some of the commercial payments from some of the hospital networks and health plan providers. Next slide, please. So I'm not going to spend a lot of time, but clearly our project was focused on social determinants of health. As you all know, these determinants are really impacting severely on our elders' capacity to self-manage in their home or in the community, whether it's a SNF facility or CCRC or other types of facility. We notice also a fairly large population living in a born and care situation that also faces many social determinants of health. Food insecurity is a large portion of these. Access to care, as I mentioned, housing is a big to-do here in Alameda County. Mental health with addiction and behaviors. Transportation can also be a barrier to access to care. Education, and by education, that means the patient ability to understand, but also the knowledge of what services and can be available to them from the community. Income, and we heard the income disparities across the county. Isolation, as you know, the family hub has changed gradually over the years, and we have more seniors and elders living by themselves, caring for their own medical and social needs. And then lastly, environment and safety. Next slide, please. The impact of social determinants of health is essentially that 80% of those determinants will impact a person's health that are non-clinical in nature. If you look at that slide, 40% of social determinants of health are either social or economical in nature. 30% are behavioral, and 10% are environmental. So clearly the largest portion being social, we feel we have a real opportunity to impact favorably on these social determinants of health. Next slide, please. So this is a guide from, if we could go back to the previous, thank you. This is a slide from cms.gov, also reflecting on the importance of social determinants. So not only is the county, our state, sensitive to the need to impact on social determinants of health, but our country at large and CMS are now really focused on how to address those needs for our communities. And again, CMS will state that it is important to connect patients with community-based resources, such as adult day health programs, personal care, home-delivered meals, services that address social determinants of health. So again, not rocket science, basic needs that need to be met in the community to stabilize and offer comfort to our seniors. Next slide. So the part of the plan from CMS perspective is to focus on systemic response to social determinants of health. What that means is creating systems that respond to the needs of our population and focused on diversity, as well as addressing the social determinants that put our community elders at risk for readmissions. So these two emphases are of interest of CMS, and we as a health plan provider want to be aligned with the vision of CMS to ensure that we put some emphasis on not only the clinical needs of our community elders, but also the social needs. Next slide. So traditionally, a hospital system like Kaiser Permanente had been working downstream, meaning we have an emergency department, and when the patient shows up, we provide care, we move the patient to an inpatient setting for treating the medical conditions. And yes, we have social services addressing social needs. And then the patient returns into the community, and then we move on to the next patient. That is the old-fashioned model of care, where a portion of the patient's needs are unmet and unaddressed. And so we are starting to move upstream, discussing and being proactive with our patients, trying to understand, in addition to their urgent clinical needs, what other social needs may be impacting their ability to manage at home. And so you can see that there is an opportunity locally to move upstream, but there is also an opportunity, as Terry mentioned, to go upstream in terms of our legislation at the state level and at the national level to address the EIDs, social determinants of health. Next slide, please. So we had put a conceptual project, and the purpose of the project was really for our local hospital, Oakland Medical Center at Kaiser Permanente, to connect and partner with a provider, an organization in the community that would help us understand the opportunities to better provide services and attend to social determinants of health for our elders. And so we connected with Wendy and our Senior Services Coalition to understand how we could proceed with the project. We started late in 2021, and we determined that we had an opportunity to partner with ElderCare. And I don't know if Patricia, if you're on the call, but we quickly connected and partnered with Patricia Osage from ElderCare to set up some communication processes and put a bit of a process in place to refer patients that we felt needed additional services in the community, so that we could hand off patients specific to their needs to ElderCare. And so we put a draft agreement, we set some specific goals, and we defined the project in a small scale. We wanted to work on understanding the benefits of that connection, that partnership, for a cohort of 25 senior patients. Since then, we've engaged and signed up, if you will, 25 patients in the program. And we've also defined some specific metrics to understand, the impact and the benefits of having that collaboration between Kaiser Permanente and then an organization like ElderCare, ElderCare. And then finally, we wanted to integrate technology to facilitate the communication between the two, using specifically a platform called Thrive Local. And we finally launched the project in July of last year, 2022. Next, please. So what kind of outcome measurements were we driven by? We wanted to understand the conversion of referring a patient to an organization in the community. Because in the past, when a social worker referred the patient for any needs, we assumed that the patient would automatically receive the benefits and the services ordered. Well, it is interesting to know that there is a certain degree of declination of that service. Either the patient changes his mind, the CBO is not positioned to offer the services, or for whatever reason, and the patient may have a copay that they may not be interested in participating in. And so there are a lot of factors that impact the decision to be a part of the CBO program and to receive services. We also were interested in avoiding recidivism in the emergency department, patients who came back and forth many times because they were too unstable at home, being unable to self-manage, and therefore coming back to the ED, not so much for clinical needs, but more so because their social needs were unmet. And we're comparing 6 months prior to the project versus 6 months under the project, getting the proper services, and also being case managed by an individual. And then lastly, our outcomes would be, we're looking for improvement in self-management from our elders, as well as social determinants of health being met, and ultimately reducing the utilization from our emergency department. Next, please.
Mr. Gigon, I do want to let you know we got about a minute left.
Okay, so thank you, Matthew. So really the vision was to have a systemic approach to answering the social determinants of health, and to continue partnering with community-based organizations so that we would maximize on the services available to our patients and to community elders. Next slide. So really that concludes my presentation. We currently don't have any formal data because we will finalize the impact of our project by the end of June. What I can share with you today is that we've noticed a significant reduction in utilization from the emergency department, a more stable status of our 25 cohort in our patients and community members, and also a certain degree of happiness from our patients being cared for and having someone to rely on through the case management person from Life ElderCare. So the learnings in conclusion are that so far it is a very favorable project that helps us to learn more about community services and how we can align all the work across the organizations. So I'll stop there and see if there are any questions for me. Thank you.
Hi, Roland. I think we'll, for now, because we are running a little behind, I'm going to try and move us along. We'll try, if there's time at the end, we'll ask for questions. I believe there's some questions come up in the chat, so I believe you'll be able to answer those and then can get back to the person at a later time. So for now, then, I will introduce Sophay, who goes by Pi, I believe, Duch, and Pi, you are up.
Yes. Hi, good morning, everyone. So my name is Sophay. I just go by Pi. I'm a licensed clinical social worker, and that's the lens that I work from. And I'm going to be highlighting the partnership with Life ElderCare and Kaiser Oakland. Next slide. So before jumping in, I just want to kind of highlight our mission. So Life ElderCare, we serve Alameda County, folks that are 60 and over, and our mission is to empower the aging to live with independence and interdependence. And so, you know, as a case manager or a social worker on the grounds, I'm always interested in what are the nuts and bolts of how a policy gets executed. Like, what does it look like? What does it sound like? What does it feel like? And so that is part of what drives me into doing this work. Next slide, please. So The services that are provided by our organization, Life ElderCare, includes Meals on Wheels. We serve the Tri-City, transportation, friendly visitors, Health Ward, or our fall prevention program, and I manage our case management program. Next slide, please. So when entering the project with Kaiser, both sides acknowledge that we had strengths, and then we also acknowledge that there are gaps in services and opportunities for us to partner and kind of highlight those strengths. Folks that enter the ER have short-term care, right? They go in, they get treated, and then they get discharged home. So the follow-up is difficult. And so on our end, we really focus on meeting folks where they're at, like post-hospitalization back in the community. So as I mentioned, the project aims to develop a more consistently effective method with the goal of providing more person-centered care and improving outcomes. Next slide, please. So Roland mentioned the social determinants of health already, and I just want to kind of delve into it a little bit more. So as many of us know, that a person's health outcome can be very, very linked to their environment, their environmental factors, right? So food insecurity. So if the person lives in a food desert, for example, East Oakland, which we serve a lot of folks in that area, not having adequate access to food really can impact the person's medical issues, right? Caregiver support, not enough long-term care planning support. And a big thing that I see is social isolation, right? So it could look like the person has outlived their families and communities, and they really have no one else. And so that is a huge barrier for them. And oftentimes people wait until things get really bad in terms of their health to access care. And that can be linked to isolation. Next slide, please. So in terms of identifying the population, we kind of have to narrow it down because it's not a one size fits all. We don't do everything, right? So we wanted to really focus on what we do well at Life ElderCare. And so this is why we selected to work with folks that are 60 and over, because that's the population that we serve. Folks that are using the emergency room often, and exploring the reasons why. Folks with chronic illness, history of mental health challenges, risk of loss, risk of social isolation. So those are kind of like the framework we explored in thinking about, well, how would this work? Who is it going to be? How do we try to explore these issues? Next slide, please. So some of the trends that we're seeing is that the average age, interestingly, that have been referred to us is 80 years old. 32% have caregiver needs. 41% stated that transportation is a barrier to accessing care and accessing social things like bingo or visiting friends or even grocery shopping. And majority or a big part of what I'm seeing is 41% are needing some type of dementia care support. Next slide. So some of the services explored and provided. So in terms of dementia care support, folks that have also cognitive impairment, what we do is we do a biopsychosocial assessment. So really trying to explore like their whole system, their internal system, and then their environment. Identifying care needs, helping folks develop short and long-term care plans that are culturally sensitive, realistic to their life situation, and not set in stone, right? Like it's not prescribed, it's a collaboration between us and the folks that we're serving. And within the dementia care support, we also have been supporting people to review and identify memory care and assisted living if they are that point. But we do try to help people age in place and think about what options that person or their family has. And going on to transportation, so we're trying to assess the barriers to accessing their care. And for folks that are elderly, it's really difficult to make it to your appointment if you have 4 flights of stairs to go down and you can't go down by yourself, right? So we have connected some of the participants in this program to our door-to-door program, which is our transportation at Life ElderCare. This transportation programs, majority of the drivers are volunteer based, and they get the person or meet the person at the door and then takes them to medical appointments, for example, and waits with them and then takes them back home. So really trying to explore what types of appropriate transportation would be helpful for the person so that they can access care or access their basic needs. And in terms of caregiver needs, that is a huge, huge issue, as many other folks have expressed. So some of the things that we have helped people do is connect to in-home supportive services, connect caregivers to support groups, help people apply for the home and community-based service waiver program, and then explore private pay caregiver options. Next slide, please. So I just want to kind of take a step back because there's a lot that I can't fully express because of the time limit, but it isn't rocket science, right? Like when I reach out to a person, I kind of tap into, I'm Cambodian, so I tap into how we greet people in my culture is we say, "Nham bang no," which means have you eaten rice, right? Like asking a person and engaging with them in a human level of, have you eaten yet? Are you okay? Do you feel safe? How do I support you? Right? You're the boss. I'm not here to pressure you to take anything on. This is your life. You know yourself the best. I'm here with your consent and whatever that means for you. And so really honoring the person's autonomy and choice empowers the person to engage in the support, right? Like actually seeing them as a whole person. And so I'm so excited about further exploring different options because I feel like this type of partnership can really, really benefit a lot of people in our communities. And I hope that we can roll this out to the rest of the county and the rest of California. And so with that, thank you so much, everyone that's here. I'm really grateful that we're having this conversation. Thank you.
Great. Thank you, Pai. Thank you, Roland. So I think we have time for just 2 short questions. I'll try to, I won't make them as difficult as Quayle did with her large questions, but maybe just for Roland, you had mentioned the upstream work, and I was wondering if you could talk a little bit more about that as far as how does a healthcare organization transition from the downstream to the upstream?
Yeah, so thank you for the question, Matthew. So looking at upstream means we want to identify individuals from the community who have a variety of needs, and by identifying them, be upstream by setting some processes and workflows that will link the patient to organization and benefits in the community. And so what it means is we are developing teams, clinicians and social workers who are in the process of identifying members who have a certain level of social needs, whether it's homelessness, whether it's behavioral health, and whether it's limited funding and poverty, or obviously age is a factor. And so we tend to be more sensitive to the demographics of our patients, so that we not only manage them when they are in the ED in the hospital, but we also follow them in the community. So for instance, we now have a transitions program that includes nurses and social workers who will follow up with some of those identified individuals who need additional help and connect them with a variety of services, whether it's provided by Kaiser Permanente or from CBOs in the county.
Wonderful. Thank you so much for going through that.
Thanks for asking.
And then Pai, first, thank you very much for making your presentation so personal, especially at the end there. So my question for you is, if you could just touch on that a little bit more. So what else can organizations do to make that care more personable, or make that outreach, or make it more culturally responsive? I just want to...
Yeah, thank you. Again, I think the intervention is literally just meeting folks where they're at, right? Like actually going into their home with their consent and exploring some of the challenges that they're experiencing. And one thing that has come up again and again is this idea of compounding disabilities, right? Like there's the physical disability, and there's also like challenges that are people that are experiencing that are not visible, right? And so an example of that is folks that are that have developmental disabilities, right? They've experienced this since childhood, and they're in their 60s, they still have that. And so this person may not be able to complete forms or follow up with certain applications because it's challenging for them to process that much information. And so actually meeting them where they're at, identifying what their strengths are, and then helping them advocate for themselves to get the resources that they need in a way that's dignified, right? I think oftentimes I've heard a lot of comments like, oh, this person's refusing services, or this person's non-compliant, right? Like I suggested this care plan and this person's not doing it. I'm the expert. They need to follow this, right? So I think as providers, we have to take a step back and think about how many times have you gone to the doctor and the doctor says, you have to exercise 3 times a week. You should eat these meals. And how many times did you actually follow that, right? Like I'm pretty non-compliant with certain care plans, right? So I think normalizing and humanizing what people are experiencing and acknowledging that there are challenges, and I see you and I'm here to support you, but also supporting people to identify things that are realistic for them in terms of like where they're at and what type of maybe non-visible disabilities or challenges that person is experiencing. Thanks.
Wonderful. Thank you so much. I think now we'll move on to our next set of panel, our speakers. And up next, I believe we have, sorry, I just lost my spot. Sonya, I believe, Sonya, you're up.
Hi, good morning, everyone. So I'm Sonya Frost, a division director here at Alameda County Department of Adult and Aging Services, and Pamela Powell, which is a program manager, will be actually co-presenting, but I will go first. And so as thank you for this invitation. And as I was listening to just some of the presentations, I was really just observing some of the commonalities. And currently here at Alameda County, we're in the process of budget season. And I'm submitted what we call MOE, a maintenance of effort, which is really just to give the county auditor's office a summary of who we are serving and what we're doing. And so as I was looking at last year's budget, I saw that 63% of the APS clients that we serve actually have incomes of $25,000 or less, which is like astounding. And then another interesting statistic was that we had an increase of 37% increase in isolation cases here in Alameda County. And race-wise is that four of the 5 clients that we serve here in APS are identified as minority or multiple races. So those are some of the statistics. And so with that said, we're going to talk about our Home Safe program. And Home Safe program was established in the year 2018 at the California state government level. The good thing is that Alameda County was one of the key counties that played a key role in drafting the legislative proposal for this state funding. And as a result, when it was approved, Alameda County had a grant of about $955,000. And once this program was permanently implemented at the state, now Alameda County has about a $3 million budget for Home Safe clients. So with our Home Safe program, how we use our services are mostly through contracted providers. So we have grantees that operate at a local level, and they utilize a range of services to support our housing. Actually, you can flip to the next slide. I'm sorry. There, no, one more. Let's see, one more. There we go. So we have, and they utilize a range of services to serve our clientele, and they're all governing around housing related services. So one is intensive case management, and that is that we use what we call our housing first principle. So irregardless of what other things you have going on, housing is a primary need. So we don't exclude you if you have addictions or you don't have funding. You know, the goal is to make you to help you be housed. And then they also offer other assistance around housing stability, case management services, and they use motivational interviewing and a trauma-informed approach. We also provide a core component of housing stabilization, and that's simply case management and direct financial assistance. Some of the services under there would be rental assistance, promotes community integration and allows them, our elders, to age in place without having to be placed in skilled nursing facilities or boarding care facilities. We also have housing navigation. Our providers use housing navigations, which is a critical component in helping clients to get placed. And so simply what housing navigation is assisting clients in finding housing, applying for housing, securing housing, and actually assisting them to move into the housing. And that could be in terms of finance or other forms of support. And then a big part of Home Safe is our housing direct financial assistance. And on a slide coming up, I'll actually show you the amount of money that we use in regards to housing assistance. But it is like it's direct financial assistance that represents all the different costs that are paid out to safely house our older and disabled adults. And then lastly, we have connections to longer term support. And what that is that Home Safe is looked at as a temporary housing solution with the goal of helping that person to be housed permanently. And so for us, temporary may be hotel or motel vouchers for a period of time. It may be allowing a client to live in a supportive, independent living situation in terms of like an emergency housing, which could be 90 days, it could be 6 months. But the goal is we want to stabilize them and help them to get permanent housing. Next slide, please. So who is eligible for Home Safe? I actually included in one of the handouts, we developed kind of like a 2-page cheat sheet for you all that it should be attached. But those who are eligible are, you have to be an APS client, right? And you can be in the process of intake, which means a phone call comes in and it's Sally needs help. And you're speaking with an intake worker. So you can be an intake or you can be assigned a case in the investigation process. The second eligibility requirement is that the person is homeless or they're at imminent risk of homelessness as a result of elder or dependent abuse. And those could be under the categories of neglect, self-neglect, or financial exploitation. And then the last eligibility requirement is that this is a voluntary program. And I think I've heard someone else say that we meet clients where they are. We don't force clients. They have to volunteer to participate in the program. And so just to give you a working definition of what we consider is homeless or at risk of homeless is that the person is absent of a fixed or regular nighttime residence. The person is in receipt of judgment for eviction as ordered by the court. A person has received a pay rent or quit notice, and they could be at risk of losing their primary place of residence. And a person who has a primary residence or a living situation that is directly associated with a substantiated report of abuse, neglect, and other risk factors. And what that could look like is that, you know, they could live in their household and there could be a relative that is being abusive to them, and it's just not safe for them to remain in their current residence. Okay, next slide, please. Okay, and this is just a quick overview of, which I mentioned earlier, the Home Safe funding allocations. And the $92.5 million is the overall allocation. And this is available for us up to June 2025. So we're going into fiscal year 2023. Can you go back? I'm sorry, I was reading. Yeah. And so Alameda County's allocation is a little bit over $3 million per fiscal year. So the 92.5 million is the overall state budget. Alameda County, being one of the largest counties, is allocated $3.3 million a year. And there's no match requirement. Next slide, please. Okay, so tangible services, as I mentioned earlier, is a funding stream that we use to provide direct costs to our clients. And as you can see, tangible services is a pretty large category. Tangible services could be food, transportation, emergency shelter, in-home protective care, and it includes a multidisciplinary team. Also, we pay for public health nurse services. We also use it towards case management services and then prevention and legal services. And I actually see some of our Home Safe partners like Legal Assistance for Seniors. I see some of our daybreak providers actually on here that serve our clients in Home Safe. So just a overall summary. The tangible services expenditure, the dates of this funding is kind of backdated. Apologies to that. Our data person had a family emergency, so we couldn't get updated data, but the current data is not that it's not that much of a difference from what you see here. But if you look in the upper right-hand corner, you can see that we pretty much spend about $700,000 a year on tangible services, which is a lot. And so some of the tangible services are directly related to home safe clients, which is a little over the $200,000 mark. And then you see up to almost $500,000 in tangible services for general services. And if you look at the circle on the left, you'll see the different amounts that we spend on tangible services, such as utilities, linens, emergency food, respite, medical, psychological evaluations, temporary in-house caregiving services. And then we have housing stability and emergency shelter, transportation, and so on. Next slide, please. So at this point, I'm actually going to turn it over to Pamela Powell, the program manager, who's directly responsible for the program of adult protective services.
All right, thank you so much, Sonya, and good morning, everyone. Again, my name is Pamela Powell, and I'm going to talk a little bit more about our tangible services. So most clients referred for tangible services are helped with the lightest touch possible, which translates to about 60% of our clients served using only about 20% of the allotted funds. The cost of services range from about $60 to $2,100. So this means that a small number of our more intensive cases were able to be served with the majority of the funding as they required a greater cost for their interventions. The cost of services for the more intensive cases averaged from about $10,000 to $24,000. Next slide, please. So just to reiterate what Sonya said, home safe funds in Alameda County are being used across 3 categories, which are the home safe flexible funds or tangible services, case management and housing navigation via our community-based organizations, and as Sonya said, a lot of them are on the calls today, and legal assistance through a CBO or legal assistance for seniors. So just a quick history. Alameda County played a lead role in drafting the original legislative proposal, which resulted in the allocation of $15 million in state funding for the 3-year home safe pilot program. 24 counties across the state were awarded grants, and Alameda County was awarded $955,000, which was the 3rd largest grant due to the size of our county. And the Board of Supervisors accepted the grant on May 7th, 2019. And the Home Safe program has just evolved since then. And again, like Sonya said, now we have a $3.3 million program. So Alameda County has served about 52 clients under the Home Safe program. And this is out of the approximate 1,600 clients served statewide. So on a state and local level, APS referrals begin with an allegation or allegations of abuse, neglect, or exploitation. Most home safe referrals included allegations of self-neglect. So self-neglect allegations are very common. APS staff statewide explains to project evaluators that their client's self-neglect may have led to an actual or threatened eviction from their residence. APS workers also noted that self-neglect can be interpreted as faulting the client when the client doesn't have the resources or ability to maintain their health and welfare. And when support systems are frayed by economic challenges or unforeseen circumstances, such as the COVID-19 pandemic, this further exasperates their circumstances. Also, with that, case management is needed in most of our home safe cases, as very few are able to be helped by tangible services, legal services, or housing navigation alone. Next slide, please. So now I'll share a client story with you. We had a 79-year-old woman who we'll call Barbara, who was living with her granddaughter. Barbara, her granddaughter was also her IHSS caregiver and SSI payee. So the reporting party is a family member who talks to Barbara regularly on the telephone and occasionally visits her in the home. This family member reported allegations of neglect and psychological and physical abuse, stating that she witnessed Barbara's granddaughter curse her out and then fling her to the ground. This wasn't an isolated incident. Barbara told the APS worker that her granddaughter has hit her on the back with a broom, among other acts of abuse. She also said she's not allowed to get food from the refrigerator for herself, and that if she does, she'll actually be hit by her grandmother. And so she remains hungry at times throughout the day. Because of her fear of Barbara's granddaughter, no one in the family has done anything about this because they're very intimidated by her. Barbara's been diagnosed with dementia. She's able to articulate her feelings and wishes, but does not remember how many children she has. When her granddaughter was out of the house, the APS worker and a home safe case manager was able to help Barbara safely leave the home and took her to a room and board for safety. The granddaughter was furious when she found out and called APS repeatedly. We always made sure we consulted with Barbara, and she never wavered. She did not want anything to do with her granddaughter at all. We continued to work with the client and to find names of family members that she was interested in speaking to. APS is paying the room and board, and we've also purchased clothing and personal hygiene items for her. Home safe case management provider took her to her primary care physician and refilled 5 of her prescriptions. She only had 2 of the prescriptions at the home. She was still in need of dentures and glasses. Barbara said that her granddaughter took them from her along with her ID and her purse. APS was able to locate a grandson who didn't have any ties to the granddaughter, but was also raised by the grandmother, and so they had a relationship. We arranged for a meeting at a Starbucks, and Barbara was extremely excited to see him, and the feeling was mutual. It was a really, really lovely reunion. The grandson lives in another county, in San Joaquin County. He's gainfully employed and has been working from home for the past 2 years. He's married and has children and has a spare bedroom. We spoke over a period of several weeks with him and his wife and Barbara. We talked about the pressure that he may get from the granddaughter to bring Barbara back because she is the source of thousands of dollars per month for income for her. And this would be quite a problem. He's aware of this and is ready to deal legally with the granddaughter if necessary in order to take over for his grandmother's finances and IHSS status. So the plan is to have Barbara move in with her grandson. We're also in contact with our partners over in APS in San Joaquin County to assist assuring all resources are being utilized and that the client remains safe. Next slide, please. So thank you so much for your time and attention. And that concludes our presentation.
Great, thank you so much, Sonya and Pamela. I have a lot of questions about the Home Safe program, but I think this will have to wait for another day. So hopefully I'll probably contact you offline. We do unfortunately need to keep moving. So if you do have questions, please put them in the chat, and then Pamela and Sonya will be able to answer them at a later point. So at this point, I would like to introduce Serom. Serom, you are up.
Great, thank you. I'm thrilled to be here with you all today. Could we get my slides up, please? Thank you. Next slide, please, actually. Great, thanks. East Bay Innovations, also known as EBI, started in 1994 with a mission to empower individuals with disabilities to live in their own homes, work in jobs of their choosing, and be a part of their community. We provide independent living skills training, supported living services, and supported employment services to individuals with developmental disabilities. And we also provide transitional care and case management services to individuals exiting long-term care facilities and comprehensive case management to low-income adults with disabilities with complex chronic health conditions and/or housing instability. We've been doing skilled nursing facility transition services as part of the federal Money Follows the Person pilot and the state California Community Transitions Project since 2009. We're also excited to pilot nursing facility transitions with Alameda Alliance with the new CalAIM expanded population of focus. Today, I won't be going into specific details of eligibility for a single program, but I'll focus on how EBI approaches person-centered planning, uses systems planning. I'll share a success story as well as some common challenges and gaps in transition services that we see. Next slide, please. When we're doing assessments and intakes, one of the most common things we hear from residents of long-term care facilities is that it feels like they're in jail. They're in an institutional setting, often without having had much choice in being there. They feel that they're stripped of their agency and dignity and who they can visit, who they can have visit, when they can go out, when they come back, what they eat, what they wear, what they can keep at their bedside, etc. We've worked with many individuals who live in the facility and keep all of their personal belongings with them at all times because they're concerned it would be stolen. And we've also worked with many individuals who've experienced neglect, abuse, or assault, both from other residents as well as from facility staff. As Denny Chan and Dr. Terry shared, we saw throughout the COVID pandemic how equity and access disparities existed in nursing homes and how our seniors and individuals with disabilities, especially those from marginalized communities, were disproportionately impacted. I would highly recommend a briefing that was released by Justice in Aging on racial disparities in nursing facilities and how to address them. Very informative. Next slide, please. It takes a lot of work to help someone shift from a place of disempowerment to a place of empowerment, and this takes trust. It's essential in helping the individual transition from institutional care back to the community, and it's critical in their long-term success. A big part of this trust building is transparency and honesty. So for example, I never promise an individual that I will transition them or that I will house them or do anything that I can't 100% guarantee and control. I tell them that what I can promise them, and it's that we do our absolute best to work with them to accomplish their goals. We're also transparent about the length of time it may take, so we're setting realistic expectations. Some transitions can be relatively fast, while some can take months or even years. Next slide, please. Throughout our work with individuals, as well as the nursing facilities or hospitals, we're often having to center everyone on what our mutual goal is. The end goal is for individuals to have long-term success, and this generally looks like long-term health and long-term housing retention with the goal of being able to age in place. That's the most common desire of the folks that we support. The health and the housing, they go hand in hand. Providing education, resources, and thoughtful planning for individuals to be able to access both is essential in transition planning. Next slide, please. So during the initial phases of working with an individual, we engage in comprehensive assessment and care planning that helps build the roadmap for the transition plan. That's the top white circle. And then there's two tracks, if you will. They work as separate wheels on a bicycle. They're both essential in order for the bike to move forward. The one wheel is the red section on the left, and it's around housing, making sure that the individual has a long-term, affordable, accessible place in which they can actually safely age in place. The other wheel is the yellow section on the right, and that's around their healthcare and social service coordination. So making sure the individual has a solid plan around their managed care plan, their medication management, their caregiving needs, food, transportation, social support, and other such needs that really, those are the things that make or break whether they will end up back in an institution or able to stay at home. So both of these wheels require a good amount of exercise from the client. It requires their motivation, engagement, ultimately their desire. And the specifics of each of those wheels is determined by the client, their wishes, and their unique needs and preferences. When we're transition planning, what we're actually doing is extensive post-discharge planning, or what I call systems planning. Next slide, please. So aside from the client riding their bicycle with two strong wheels, we've got the various systems outside of the client's control. And this is like the road or path. So we're not supporting our clients out of an institution only to go on an unintentional off-road dirt bike adventure. So oftentimes the programs or new systems that are created, they're made to try to meet clients' needs, but the difficulty is that the clients have to fit within the systems and their specific requirements. It makes a shift from person-centered to system-centered, and that's where we see disparities in access. We do our best to have a full picture of the landscape of services available to our clients. This helps us to plan to fit the systems to meet the client's specific needs. So knowing the various resources around home and community-based services, having strong housing partnerships, creatively looking at assistive technology, and the continuity in the relationship from pre-transition to post-transition makes the systems planning, essentially helping the client move through the systems instead of being stuck when they don't meet criteria for a specific program, key to the individual's success. Essentially, the systems planning is about removing barriers for individuals and improving access. Next slide, please. So I'll share an example of an individual that we had supported to transition out of a nursing facility. Joe, we'll call him Joe, has been at a nursing facility for over 5 years with multiple sclerosis, paraplegia, and depression. He had extensive ADL support needs, a Hoyer transfer, was incontinent, needed extensive coordination for medical equipment, and housing search that would be accessible, as well as post-transition caregiving needs. Joe had shared how being in the nursing facility long-term really exacerbated his depression. And while he did have some family visit him from time to time, and he also had some people at the nursing facility that he enjoyed talking to, he really wanted to be a part of the community and have his life back. Because of the extensive medical equipment and care needs, we had to get really creative with what we could find for Joe and really hearing what his desires were. So we identified with him that what he would likely need was a 3-bedroom unit to accommodate a live-in aid and all of his medical equipment. We were able to get approval for a flexible health housing subsidy to find a unit suitable for Joe. We found a 3-bedroom house, negotiated rent with the landlord. We identified modification needs for accessibility. We worked with contractors to make the unit accessible, and we helped Joe transition back to the community with the support of a live-in aid, a team of caregivers, connection to community clinics and mental health care, transportation, food resources, and a referral to a nearby church, as attending church in person was a high priority for Joe. He had very specific medical supplies, so we also made sure that the managed care plan he was opting into was vendored with the medical supply company and able to deliver his products. And for some items that were not covered by his insurance, we connected with the housing authority to make sure that his rent was reduced to account for the out-of-pocket medical expenses. He was set up with medication delivery and also set up with a life alert device. We also supported Joe to report his change of living situation to Social Security so that his benefits could be fully restored to the community living rate. And in coordinating Joe's transition and post-transition support, we helped Joe navigate through multiple different systems or funding streams to provide a seamless transition with no gaps in service. It's been almost 4 years since Joe transitioned to the community. And while there have been plenty of challenges along the way, Joe has had no unplanned hospitalization since his transition, and he's been thriving in the community. Next slide, please. A common challenge we encounter is that change is hard for any of us, right? And shifting from institutional care in particular to community living can be both exciting and daunting. We hear some clients say how their first night back in the community was so amazing. And we hear an equal, if not greater amount of clients share that the first 24 to 48 hours is terrifying. They had gotten used to being able to ring a bell and have someone right around the corner, or had gotten used to there always being just other people around, or not having to direct so much of their care and life. And that adjusting back to being able to make the choices they wanted to make can feel scary and like uncharted territory doing this with oftentimes a new disability. Another common challenge is probably one that most of you are familiar with, and it's the shortage of caregivers. Using the public authority registry list to hire and train IHSS caregivers that would be lined up to provide services on day 1 of transition and onwards is a real challenge and barrier to transitions, and oftentimes where we get the most stuck. I'm personally very eager to see the rollout of homemaker services through CalAIM in our county and looking forward to that. One gap that we see is flexible funding that crosses the health and housing sectors. We've been able to pilot a flexible health housing subsidy with Alameda County Healthcare Services Agency and have found that being able to navigate through settings such as apartment complexes, single family homes, shared housing, all the way to licensed residential care facilities has made a significant difference in our ability to quickly transition individuals out of unnecessary institutional stay, decrease unnecessary utilization, and increase quality of life. And through this, we've been able to build a small network of trusted providers and our property owners who are willing to work with us and will proactively reach out to us when they have open units because they know that the client will come with ongoing services from EBI. However, funding and slots are limited, and we'd love to see more flexible funding such as this that can be used across a variety of settings. Next slide, please. I won't go into the details of this list, but they're all hyperlinked, so anyone can go through them and learn more about the various programs that we most often use or that we provide services through or provide direct linkages to. Additionally, my personal favorite go-tos for resources and filling my own knowledge base is Canner and Justice in Aging. I highly recommend getting on their listservs. Another good one is Disability Rights California. I didn't mention them on this resource list, but they're also an excellent resource. Next slide, please. And finally, here's my contact information if anyone has further questions that can't be addressed during the Q&A. Thank you.
Wonderful. Thank you so much. I'd like to thank the panel. I know we have a hard stop right now, so unfortunately we don't have time for Q&A, but there are a lot of questions in the chat, so hopefully you'll be able to go in the entire panel. I believe there's questions for everybody. Maybe you can go in and answer those. So I want to thank the panel. Wonderful conversations. Thank you for all the amazing work that you're doing in the community. And at this point, I will turn it back over to Wendy.